Okie dokie. We're going live. Good evening, everyone. I think we're all coming on board. Good evening, good evening, good evening. And I also have the Facebook crew going as well. All right. Happy Friday, everyone. Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractic physician at Gates Brain Health. And tonight I'm talking about understanding thyroid physiology. This was by request. There's so much discussion about the thyroid. I've kind of been steering clear of it because everyone and their grandmother is talking about the thyroid, and everyone is a thyroid expert. Our staff has and good evening to everybody who's joining. So thankful you're all here with me. In all sincerity, truly, truly, truly. The staff wanted me to talk about Hashimoto's thyroiditis and thyroid physiology because lots of times I'll just kind of glance over the issue, or we have a lot of patients who have it, and we really seem to see some pretty good success with our Hashimoto's and thyroid patients in certain domains. And I think it's prudent that we go into this. So that's why I'm talking about the thyroid. I didn't talk about it the other night because I was not finding a good graphic for you describing the thyroid physiology. And so Melanie was so kind to sketch something out. So we have that in store. And I wanted to kind of have a nice presentation for all of you to kind of recap thyroid physiology. I've been in practice for 11 years now. So 11 years ago, no one or very few people were talking about the thyroid. Very few people were talking about gluten and the thyroid. And then within the first 6 years of me being in practice, that completely changed. And then everyone was then becoming an expert on the thyroid and knowing about gluten and the thyroid. And by 2014, I think 100 million Americans tried going gluten-free, largely because celebrities were touting the diet and their benefits in terms of weight loss and feeling better. And so that was prompting a lot of people to go gluten-free. And then that also prompted a lot of backlash from certain members of the nutritional community saying that if you don't eat gluten, you don't eat cereal grains, and we're going to be deficient in vitamins and minerals. And that's kind of the prelude to the story. And through the years, I've become very neurologically focused, as most of you probably know who watch me regularly. But with all those neurological problems, certainly autoimmunity to the thyroid can have an impact. Autoimmunity to things like gluten can have an impact. So I certainly work with the thyroid, but again, I haven't been talking about it much. So, and if you're commenting live on YouTube, then I'll probably see those later. I can see the Facebook comments right now. For all of you Facebookers, probably would be good if you watch the YouTube because I did put a lot of work into it, and I think it may help the discussion to come into view. But you can go back and watch it later, whatever works for you. Okay, so the thyroid. The thyroid here is Melanie so nicely sketched out. Sits kind of at the base of our anterior portion of our cervical spine, our neck. Well, not really our cervical spine, our cervical area. And it's down here by the Adam's apple is what you would perceive there. And as you can see here, this is referred to as the thyroid cartilage. This is the cricoid cartilage. And then you have the thyroid. The thyroid very much looks like a butterfly, if you want to think of it that way. It has two lobes on each side, and then it's connected in the middle by an isthmus. And I think they call it like the Isthmus of Panama. So an isthmus connects two structures. So the Isthmus of Panama does not apply to the thyroid, but just so you know, I'm discussing isthmus, ISTHMUS. And so when we have a thyroid, we can develop nodules in the thyroid. That's really important to consider. Some people develop a goiter where the thyroid really enlarges. And one of the things that doctors learn in medical diagnosis is the swallow test. So you can have someone lean back, Give them some water, technically, have them swallow. And if you see this big lump down here, aside from the Adam's apple, but if you see this big lump, then you may want to think, whoa, does this person have a goiter? Does this person have a really large thyroid nodule? So those are things to take into consideration. And then what is the thyroid? So the thyroid has follicles. You can think of it as having follicles which contain the substance called colloid. The thyroid weighs about 10 to 20 grams, and we store thyroglobulin in the thyroid, and that's going to be important relative to lab testing as I go through the presentation. And so the thyroid is very dependent on iodine, and iodine is absorbed in our stomach. It becomes iodide. Iodide is then absorbed back in the thyroid and converted back into iodine by the TPO enzyme. And then the stomach, well, I just gave it away, but the thyroid has the sodium iodine ATPase. That's how it absorbs the iodine, the iodide into the thyroid. And I put here on the PowerPoint presentation what other autoimmune condition involves the sodium iodine ATPase, and that is the stomach, as I had just mentioned. So the stomach and the thyroid both have this transporter for iodine, and it's thought that that may be why there is such a large overlap between autoimmune gastritis and Hashimoto's thyroiditis, because those are the two structures that are commonly discussed having this sodium iodine transporter. So that's the reason why 40% overlap of those two autoimmune conditions. So thyroid peroxidase. What does thyroid peroxidase do? So thyroid peroxidase is an enzyme within the thyroid that does many things. First of all, it's going to convert that iodide back into iodine, and then it's going to connect iodine to tyrosine molecules. You may have heard of tyrosine in energy drinks. Tyrosine is a precursor to dopamine. And so the thyroid peroxidase is going to connect the iodine to the tyrosine molecules, and those tyrosine molecules are going to be connected to thyroglobulin. And we're going to get a variety of these iodine tyrosine molecules. You may have mono iodine tyrosine molecules. You may have diiodine tyrosine molecules. You may have triiodine tyrosine molecules, which is T3. And you may have 4 of these iodine tyrosine molecules, which is T4, also known as thyroxine. Thyroxine is inactive thyroid hormone. If you are taking levothyroxine, that's thyroxine. If you're taking Synthroid, that is basically thyroxine. And so that's the physiology of it. So again, in recapping, we consume iodine in our diet, becomes iodide, absorbed, goes into the thyroid, becomes iodine again, and then it attaches to tyrosine, and you can have 1 or 4 of them, and they get kind of assembled together, and basically you have T4, thyroxine in your thyroid, and you have T3. Then, let me see here. Okay, I think I pretty much discussed that. So one thing to consider would be what does life look like if you don't have a TPO enzyme? And so if you don't have a TPO enzyme, then you're going to have trouble taking that iodide and making it into iodine. You're going to have trouble making these iodine tyrosyl molecules. So you're going to have trouble making thyroid hormone if you don't have a TPO enzyme. And what is Hashimoto's thyroiditis most commonly associated with? It's associated with thyroid peroxidase antibodies, as I choke myself. So it's associated with TPO antibodies. So that's where, through time, if your immune system is attacking thyroid peroxidase, then you may very well have trouble making thyroid hormone, which is why Hashimoto's, well, it's one reason why Hashimoto's causes hypothyroidism. And it turns out the Hashimoto's is the most common cause of hypothyroidism. And the estimates vary depending on who you talk to. Some estimates say 70%. LabCorp, many years ago I read, they came out with a study saying that they saw with repeated testing of blood. This is important because you may have hypothyroidism and you may not test positive for having Hashimoto's. But the LabCorp folks just kept testing the blood of all these thyroid patients who kept coming to, get their blood checked for their thyroid. And they found in the long run, if you just keep checking, basically 95% of the people they saw with hypothyroidism developed or had signs of Hashimoto's. So that is that, I think. And thank you all for the really positive comments. That's awesome. I appreciate it. Okay, so what does TSH do? So you all know TSH most likely stands for thyroid stimulating hormone. It's a little confusing because a lot of you will say, well, my TSH went up, so that means my thyroid is hyperactive, or my TSH went down, and that means my thyroid is underactive, and it's actually the opposite of that. TSH is inversely related or opposite to thyroid function. So just looking at Melanie's wonderful diagram, and I asked her if this was me that she drew, and she said no because there was no long hair in the back. But anyways, she did a great job drawing this. Nonetheless, your pituitary is going to release thyroid stimulating hormone, and the pituitary does this to tell the thyroid to kind of do its job. And what does TSH really do? TSH does a number of things. It's going to help you to make more thyroid hormone in essence, and it really tells your thyroid, more importantly, to release the T4 and T3. So basically, TSH causes your thyroid to vomit out T4 and T3. They call it exocytosis. So now T4 and T3 is circulating throughout your body, and it's primarily T4, according to most authors, that comes out of the thyroid. So now the T4 is circulating around, and it's going to get converted into T3. Most of that conversion happens by the deiodinase enzymes in your liver, in your gastrointestinal tract. I think that's around 60%. And then now you have T3. T3 is what's active, as most of you know. And maybe some of you don't know. That's totally fine. T3 is your active thyroid hormone. That's what's going to regulate your cellular metabolism. And then the T3 feeds back primarily to your brain. Rather, I should say it this way. Your brain is mainly going to be sensitive in the hypothalamus to T3. And that is going to say how much thyroid hormone we have in our circulation. Love it. And thank you all for the comments. So now your brain says, okay, we have so much T3. So now we have the thermostat. If it gets cold in the house, what happens? The heat kicks on. If it gets hot in the house, the heat kicks off. And so TSH then is going to go up or down based on how much thyroid hormone your thyroid is producing. Hopefully that makes sense. I'll pause to take a drink. So let's just say you have Hashimoto's thyroiditis going on for 5 years. Your aunt has a hypothyroid condition, and now your thyroid is struggling to make thyroid hormone because your immune system is obliterating the thyroid peroxidase thyroid peroxidase enzyme via thyroid peroxidase antibodies. And so now what happens? You don't have enough T3 circulating around, so your brain, through the thyrotrophs of the anterior pituitary, are going to then start secreting lots of TSH. So now you have high TSH, and this is how your body is compensating for it. And you, all the while, are starting to say, man, I'm gaining weight a lot easier, or I'm feeling really fatigued, or I'm starting to lose hair, or you know what, my voice is a little more raspy than it used to be, or gosh darn it, I am constipated. So you go to your general practitioner with those complaints, and they say, okay, you know what, we're going to run a blood test. And they do a blood test, and they check your TSH and maybe your T4, and it comes back that your TSH is high. Now, how high? It may be a little bit high, maybe a lot high. And if it's a little bit high, they may say, nah, you're kind of borderline. Or if it's a lot high, a lot being maybe like a TSH around 8, they're going to say, you know what, you have hypothyroidism. You need a thyroid medication. So then you go on the thyroid medication to replace what? They're going to give you thyroxine, most likely. They give you T4. And then that T4 may help you to start feeling better. Now you have more hormone. We need adequate amounts of hormone. I'm going to get into a bunch about autoimmunity and the causes of Hashimoto's, the underlying features, but hormones are good. You need hormone. Is hormone the main thing? Probably not for all of the thyroid symptoms, but it is important. Just the opposite of that, let's say that your thyroid is producing tons of T4 for whatever reason. Maybe you have a toxic nodule in there. Maybe you have Graves' disease, as it's termed. So when you have lots of T4, which then becomes T3, all that T3 feeds back to your brain, and your brain's going to say, whoa, we do not need to tell the thyroid to do its job. It is doing way too good of a job. So that's where TSH then goes down. And when TSH goes down, then you go to your doctor and they say, oh, you have Graves' disease. That's why you can't sleep. That's why you have diarrhea. That's why your blood pressure is super high, especially on the systolic side. That's why you have heart palpitations. That's why your eyes are coming out of your head. That's why your hands are shaking. Okay, and I just put this article, and it's from, I think, the European Journal of Biochemistry. For those of you who like the nuances, you can look at the activity of the thyroid peroxidase enzyme and tyrosine iodination and all those little details. Okay. So TSH functions, I talked about that. So TSH, again, helps your thyroid to bring iodine in. TSH helps the iodination of thyroglobulin. TSH then helps T4 and T3 to be going through a process called exocytosis, which is, for all intents and purposes, vomiting out of the thyroid cells. And TSH causes thyroid cell hypertrophy. This is why if you have Hashimoto's thyroiditis, you may develop a goiter. And when your doctor's doing the exam, they feel your thyroid, and then all of a sudden your thyroid feels swollen. Okay. So what do thyroid hormones do? I think that may be a blind spot. So thyroid hormones increase cellular metabolism. So they help your cells to consume oxygen. They help your cells to make more ATP. This whole process facilitates basically heat. And so when people have hyperthyroidism, they tend to be more warm. They tend to be heat intolerant, meaning they go in the heat and they have a hard time cooling themselves down through thermoregulation. Vice versa, or juxtapose would be a better way to say it. Juxtapose would be the hypothyroid patient who's what? They're always cold. They're constantly cold. It's never warm enough. And I start to smile because our office tends to run a little cold and everybody's running around here in sweatshirts and long sleeve shirts. But the hypothyroid patient, and I said that kind of jokingly, but in all sincerity, the thyroid patient, the hypothyroid patient, tends to be cold. And so they are wearing a jacket during the summertime. And they can never get warm. Why? Because they don't have enough thyroid hormone to activate the cellular metabolism to give them enough heat so that they feel good. Okay, great. All right. So, hyperthyroidism, I went through those features: tachycardia, fast heart rate, heart palpitations, diarrhea, eyes coming out of the skull, exophthalmosis, osteoporosis is important. So, especially those of you who have hypothyroidism and you may be taking a thyroid medication and your doctor is having you take so much thyroid medication that you're a little bit in a hyperthyroid range, just be aware of the risk for osteoporosis. Weight loss is a feature of hyperthyroidism. Increased adrenaline sensitivity, and that's where hyperthyroid patients tend to have a tremulousness about them, is this increased adrenaline sensitivity. It kind of enhances what we call the physiologic tremor. Because hyperthyroidism is associated with weight loss, and because weight loss is like, I don't know, one of our biggest industries here in America, a lot of doctors were giving thyroid medication to facilitate weight loss, and patients were demanding that. But now apparently there's a black box warning on thyroid medications not to be used for weight loss. Okay. Hypothyroid symptoms, just the opposite. Bradycardia, so slow heart rate. Hypotension, if your blood pressure is always low, that can be a feature of hypothyroidism. Weight gain, as my physiology teacher in college said, hypothyroid patients will look at a piece of cake and they'll gain weight. And so easy weight gain, raspy voice, carpal tunnel syndrome, especially when it's bilateral. Constipation, if you're always constipated, you may want to have your thyroid checked. And then also we have swollen ankles. And so if you're wearing your socks and you always notice that there's a sock line down there at your ankles, you may want to be checked for hypothyroidism. And then patients so often say this to me, well, my doctor checked my thyroid. What does that really mean? Most commonly, because this is what insurance will cover, they'll do a TSH test and maybe a TSH and a T4 free. And so that's what your thyroid being checked means. So they're checking thyroid hormones. For those of you in the neurological world, as I've discussed, we have comments about Maldide-Barkman syndrome. I've talked about my observation of overlap of something like Hashimoto's and Maldide-Barkman syndrome. When your doctor, quote unquote, checks your thyroid, they're looking at TSH and T4. They're looking at thyroid hormones. Why? Because they can give you a thyroid hormone. If you have this autoimmune illness called Hashimoto's thyroiditis, there's no end-all be-all medical treatment at this point in time that I'm aware of for Hashimoto's. So it's more of a symptomatic management of, okay, your thyroid's low, so let's give you thyroid hormones. But there are a lot of folks running around out there who have Hashimoto's thyroiditis, but their thyroid hormones are normal. So you can go to your doctor, you can have your TSH and your T4 checked, but it's going to come back normal. That doesn't necessarily mean that you don't have this autoimmune condition, which is called Hashimoto's thyroiditis. So the medical evaluation is TSH, maybe TSH and T4 free. The functional evaluation, which a lot of functional doctors promote, saying, we are way more thorough. And so the functional doctors are going to check TSH, T4 free, T4 total, because they want to look at the free hormone and the hormone bound to carrier proteins. T3 free, T3 total. Thyroid antibodies, which includes the thyroid peroxidase antibody towards that thyroid peroxidase enzyme, and thyroglobulin antibodies. Is the immune system attacking basically the matrix of the thyroid? And then sex hormone binding globulin, again looking at features of binding capacity to the thyroid hormones and other sex hormones, gliadin antibodies, food sensitivity testing, which I'll talk about the rationale for all of that. And the functional ranges in subclinical hypothyroidism, I think, are important to discuss, because a lot of the functional doctors now are saying, well, you know what, the medical ranges are wrong. We need to look at this in a much more narrow fashion. And in the doctor world, labs vary from lab to lab. So for example, when I run a complete blood count at LabCorp, their ranges for what is normal on a white blood cell count is like this. Whereas when I use one of the local hospitals here in Reno, their range is that. So lab ranges can vary because each lab is going to say, okay, we have 10,000 people here. Here's a bell-shaped curve. You cut off the ends. This is what's normal for us. I say all that to say that functional doctors, and they're not wrong in arguing this, have said, well, maybe our range for hypothyroidism and hyperthyroidism is too wide. And I'm trying to get it on for all the Facebookers. So maybe it's too wide. Maybe we need to say it needs to be more narrow. And a lot of these studies have, or let me say, validity for this theory has largely stemmed from infertility studies. What we're finding is that for pregnant females, the thyroid is super important for carrying a baby, producing a live birth. And, just because your TSH is below 4.5, which is the standard mark that everybody uses, doesn't necessarily mean that you're in the safe zone. And they're showing that maybe a TSH below 3 or around 2.5 is really ideal for a female carrying a baby. So that's important information. So then the functional range is 0.8 to 2.8. And I think that's a pretty good range. And once you see the TSH go over 3, generally you start to become suspicious as a functional doctor. Maybe something's going on with the thyroid. Maybe this person is developing Hashimoto's thyroiditis. They're not medically abnormal yet, but the whole process has started, which in some cases can take 5 to 10 years before the thyroid finally goes kaput and is not able to make the thyroid hormones. My qualm with the functional ranges is that there may be some over extrapolation where you can then say, well, there's a functional range for every marker out there, and then we're going to infer that because you're whatever marker. Your T4 is just a little bit low, that you definitely have a thyroid problem, which is I have not always found to be the case. So that's my take, that's my opinion, but you can talk to a lot of functional doctors and they're going to maybe disagree. That's fine, but that's my experience. Okay, what does treatment look like? Treatment looks like taking thyroxine, T4, taking triiodothyronine, T3, some compounded formulation of T4 and T3. I may have misspelled armor. Armor thyroid versus nature thyroid versus WP thyroid. These are natural thyroid hormones from basically usually animals, desiccated animal thyroid. And a lot of people in the alternative world are going to say, well, these are natural, so they must be better. And that has come into some degree of argument, because basically if you have Hashimoto's thyroiditis and now your immune system is attacking your thyroid, so now you're putting an animal thyroid tissue into your body, will that further exacerbate your Hashimoto's condition? And in my experience, sometimes yeah, and in my experience, sometimes no. And pretty much what it distills down over 11 years of my experience working in this world and seeing what other doctors do, what integrative doctors do that I've worked with, it basically boils down to finding what seems to work the best for that individual. That's what I've seen. So is natural better maybe for some and maybe not for others? And let me just pause. I love the comment that only if it's German chocolate cake. That is so funny. How common is it to switch between hyper and hypo? I can feel hyper at times and hypo at others, basically. Depends on whether somebody's taking medication. I will say early in the phase of Hashimoto's, there's something called hashitoxicosis that can happen for some people, where their immune system is attacking the thyroid. And as the immune system attacks the thyroid, literally the thyroid will vomit out thyroid hormone. And this person doesn't necessarily have Graves' disease. It's just that the Hashimoto's attack is so severe that then they throw out thyroid hormone. And that may be part of the rationale why some people early on feel like this, up and down. So look up hashitoxicosis. Got the whole panel done from endocrinologists. Love it. Okay. So I'm glad that more thorough panels are being run out there. So as I mentioned, there's this group of people who have autoimmunity to their thyroid, but their thyroid hormones are normal. That's called euthyroid, U being EU, being normal, euthyroid Hashimoto's thyroiditis. And there are also people out there who are taking thyroid hormones. They're on levothyroxine, they're taking Synthroid, they're on Armour Thyroid, or they're seeing an integrative doctor who has them on a T4, T3 combo, and they still don't feel well. They're still gaining weight. They're still depressed. They're still having brain fog. And so that has led a lot of researchers to investigate why this is happening. Wouldn't it make sense that if you have low testosterone as a guy, what do? You take testosterone and you should feel manly again. You should feel good again. That's hormone replacement. Well, it turns out it's a little more complicated than that, particularly for the thyroid. And so these researchers looked at Hashimoto's thyroiditis patients, and they looked at, controlling for their thyroid hormones. And they basically found that it's the thyroid antibodies, these immune cells to the thyroid, that dramatically impact quality of life. The thyroid antibodies are associated with brain fog. Thyroid antibodies are associated with reduced blood flow in the frontal lobes. Thyroid antibodies seem to be associated with all these other central nervous system antibodies that we haven't even named yet. And so thyroid antibodies are kind of a big deal when you start looking at these quote-unquote nebulous symptoms that many of you are complaining about. You're complaining about brain fog. You're complaining about being fatigued. You're complaining about being subtly depressed. And your doctor only has the tools they have, and so they can give you thyroid medication. They can maybe up your thyroid medication, and maybe they can give you an antidepressant, which has then rendered this large group of people, when you look at thyroid support groups, who are then investigating, well, how do I help myself? These Hashimoto's support forums, which are fantastic because now we have people sharing their information, and it's really spawned this whole functional world of the thyroid. And so that is why now people are talking about diet. They're talking about restricting gluten from their diet. They're talking about taking selenium. They're talking about eating Brazil nuts. They're talking about taking iodine. They're talking about taking vitamin D, because these factors are what people are reporting that are really helping them to feel better. And on the doctor side, we can check these antibody titers for the thyroid. Sorry, I pushed. Probably stop hitting the table. Okay, and let's just see here. How much can Adderall affect Hashimoto's? Great question. I don't really know, but that's a great question. I'll get back to you. Low testosterone as a female in menopause. Okay, cool. So I love all these comments. Thank you guys. Keep them coming. Okay, efficacy of the autoimmune protocol diet is part of a multidisciplinary supported lifestyle intervention for Hashimoto's thyroiditis. This is a pretty new article, 2019, exploring the effect of going on basically the paleo diet. It's a little stricter version of the paleo diet with Hashimoto's patients. What they found is that the Hashimoto's patients felt better being on the paleo diet. It reduced their inflammatory markers. It didn't really affect their thyroid numbers significantly. But that's just the diet. And going on, I put this article in here because I couldn't find the original article. I think it was published in the journal Thyroid in 2008, where they examined cross-association between gluten antibodies, I believe in celiac disease patients, and thyroid antibodies. And they found a significant number of people who have these gluten antibodies have thyroid antibodies, which is where in this journal article looking at non-celiac gluten sensitivity, these are folks who eat gluten and they don't feel well, that basically the most common autoimmune disorder associated with this gluten intolerance is Hashimoto's thyroiditis. And basically the predominance of Hashimoto's thyroiditis represents an interesting finding. Basically, they found that like autoimmune thyroid disease is a risk factor for developing this gluten intolerance or non-celiac gluten sensitivity. And who knows, maybe it's the gluten sensitivity that then precipitated the Hashimoto's thyroiditis. That's what a lot of people argue. But those of you who read online and read books from differing doctors, one of the foundational principles is to restrict gluten from the diet. You can go back and watch my gluten broadcast if you need more information on gluten. And then we have the gut bacteria. So the gut bacteria of Hashimoto's patients has been found to be different than those who don't have Hashimoto's thyroiditis. So now we're starting to create a link. Well, maybe these immune cells to the thyroid are forming because this person also has an intolerance to gluten. And we also know that gluten, based on Dr. Fasano's study in 2015, gluten breaks down the intestinal lining of everyone. Whether you feel it or not, whether you have a health problem or not, gluten is a toxin for zonulin, which binds your intestinal epithelial cells together. So maybe Hashimoto's patients have this problem with gluten, and when they eat gluten, then that creates this molecular mimicry response to their thyroid gland, and then that's facilitating this Hashimoto's response. Why in one person versus not another? Well, the thought is that maybe there are some strong genetic components. We see that there's a strong genetic component that if your mom has Hashimoto's, I think that a female child has about a 50% probability of having some signs of autoimmune thyroid disease on her blood work at some point in her life. Why do I say her? Because there's a female preponderance with Hashimoto's thyroiditis. So now we have gluten, now we have dysbiosis. What else is in your gastrointestinal tract? You have T regulatory cells. These T helper cells, which are part of the Th3 system, are largely dependent on vitamin D. And so vitamin D is being shown to be deficient in a lot of Hashimoto's patients, and it's thought to be very important to normalize vitamin D for Hashimoto's patients so that they have a fighting chance for their Th3 system, which tries to balance their immune system, to work adequately. Here I attach an article, High Prevalence of Infertility Among Women with Graves' Disease and Hashimoto's Thyroiditis. I don't have the study here, but when you look at infertility, which is one of the most painful circumstances that can affect a family, Hashimoto's, if I remember correctly, is the second most common cause of infertility. So if you know someone who is having trouble conceiving, if you know someone who's having trouble carrying a baby full term, then ask them, have they been checked for Hashimoto's thyroiditis? If they say, my doctor checked my thyroid, say, watch this broadcast. Because, or just say, hey, get your thyroid antibodies checked. Because lots of times that is not being done. And maybe you can show them and I can send you the research articles saying, hey, TSH needs to be looked at in this narrow range, not this range, for women who have trouble conceiving and particularly who may have Hashimoto's. So I hope that helps. Also know what's the #1 cause of infertility? Polycystic ovarian syndrome, which is where they develop cysts on their ovaries, may have abnormal menstrual cycle lengths, may have signs of high testosterone like facial hair growth or blood tests showing high testosterone. And there's a huge overlap between that and Hashimoto's. A lot of PCOS patients have Hashimoto's. And then we get into the world of EBV for all of the celery juice loving people out there. There are books that are written saying that Epstein-Barr virus, which you may know as the monovirus, is the cause of all chronic health problems, including Hashimoto's. Excuse me. I will say that Epstein-Barr virus is a smoking gun, or it may be a piece of the puzzle for a number of autoimmune diseases. But this article that I'm showing you here on YouTube, published in 2015, showed that upwards of 80% of Hashimoto's cases and 62.5% of Graves' disease cases had signs of Epstein-Barr virus living in their thyroid. That's really, really important. And they go on to show immunologically that probably the Epstein-Barr is a major component for this autoimmune response to the thyroid in these people. So it's kind of a game of cat and mouse, where when we start to look at the full picture of a Hashimoto's case, there's a genetic piece. So there's a genetic piece. There is a dietary piece. And so there may be reacting to gluten. There is a gut bacterial piece. And then there's this viral piece where now all these factors are coming together. And maybe, I don't know if I said a vitamin D piece. All these factors are coming together, which are then facilitating this out of control immune response, trying to attack the thyroid, maybe trying to get to the Epstein-Barr within the thyroid, and as a consequence, destroying thyroid tissue, creating these thyroid antibodies, which go into your brain and cause you to feel depressed and have brain fog potentially. So that's really interesting. Other features that are really important include selenium status. Iodine status is important. I was trying to attach an article last minute, but too little iodine is bad. Too much iodine is bad. For a lot of years, a lot of alternative doctors were telling people to take iodine. And if you take iodine to help your thyroid, it may make you actually significantly worse and cause you to end up in the ER if you're taking too much. And the Dan Thur study, the Danish thyroid study, basically showed that as we started iodizing salt in a number of Western countries, yes, goiters went down, but incidence of thyroid disorders seemed to increase in certain areas. So iodine, selenium, vitamin D, gluten, your gut bacteria, Epstein-Barr, other viruses living in your thyroid are all super important. And those seem to be the reasons why the immune system is attacking the thyroid, and probably some derivation of all those factors is leading to the reason why Hashimoto's thyroiditis and these thyroid disorders are increasing in prevalence. And most researchers just say, we think it's environmental. Well, I'm here to tell you that genetics haven't changed. So it's probably something to do with iodine, selenium, trace mineral imbalances, vitamin D deficiencies, and maybe changes in our food supply that may have some effect on why these issues are becoming so common. I read there was a high miscarriage rate with MTHFR. Yeah. I would say that's more of an MTHFR is methyl tetrahydrofolate reductase. It's how you take inactive folic acid and turn it into active folic acid. And people with polymorphisms of that, females with polymorphisms of the MTHFR enzyme, can have a higher incidence of miscarriages. I think that's a separate issue from the Hashimoto's link, but that is a fantastic question. So it looks like I've gone on a little bit long, but this was an involved topic. So thank you all for joining, and thank you all for commenting. Hi to everyone here on YouTube land, and have a great Friday night, everyone. Send me any other questions. If I didn't talk about something, let me know. I'll circle back and try to answer your questions on YouTube or Facebook. All right. Take care. Be safe. Stay healthy.